Well, good morning, everyone. Thank you for joining us today for part 2 of our 3-part series on UTI reduction education. Today's webinar is being recorded and will be posted as a Superior Health Quality Alliance YouTube video in approximately 1 week. All attendees are in listen-only mode. If you have questions throughout the presentation, please enter them in the Q&A. At the end of the presentation, we will open it up for all questions, at which time you can raise your hand using the hand icon at the bottom right of your Zoom meeting screen. And if you click on that, we will see it and can unmute your line. Today's webinar, Criteria to Determine Presence of UTI, is being presented by Diane Dome. Diane is a clinical laboratory scientist and has a bachelor's degree in business and has been board certified in infection prevention and control since 2008. She is also a certified professional in healthcare quality. For the last 5 years, Diane has worked as a nursing home project specialist with Superior Health Quality Alliance. Diane's main role is assisting long-term care facilities with preparations to meet current regulations, enrollment in the National Healthcare Safety Network, reduction of C. difficile and other infections, as well as antibiotic stewardship. So now I will turn it over to you, Diane.
Thank you, Tracy. And thank you everyone for joining us today. Today's webinar, Criteria to Determine Presence of Urinary Tract Infection. This is part 2 in the 3-part series on reduction of UTI. Today, we're going to discuss the various surveillance definitions that are used in long-term care to determine the presence of UTI, including McGear's, Lobbs, as well as the National Healthcare Safety Network, or NHSN, criteria. We'll also discuss evaluation of your resident before calling your provider with a change in condition. The ultimate goal of this series is to prevent unnecessary testing and antibiotic prescribing. Tracy has already talked to us about how to ask a question. Feel free to put it into the Q&A or to raise your hand. We will cover those at the end of the presentation. So why are we focusing on UTIs today? Well, it is the most common bacterial infection occurring in residents and long-term care facilities. It is a frequent reason for antimicrobial administration. And we know that antimicrobial use is often inappropriate and overused in long-term care. Also, for many facilities, we have noticed that the rates of UTI have increased since the beginning of coronavirus or COVID-19. This is seen by your minimum data set and your CASPER data. So one thing I just wanted to make clear before we started our talk today on surveillance criteria is that we are not saying that surveillance criteria has to be met in order for a provider to order antimicrobial therapy. But it is and should be part of the discussion of your resident when you're calling the provider with that change in the condition. And that surveillance criteria can be helpful in that discussion. Again, it is one tool in your toolbox. The other point is you always want to make sure and document that review in the resident care plan so that that is in the record as well. What are some of the challenges of surveillance criteria? We know that infections frequently present differently in the elderly. And surveillance criteria by their design are meant to be very specific so that you can determine your rates, but they are not always highly sensitive. So some infections may be missed. And residents with cognitive impairment may not be able to express their symptoms to you. Why is it important to use these surveillance definitions? It helps us to apply evidence-based surveillance criteria so that it's uniform across the nation. It allows consistent tracking and reporting of your symptomatic UTI within your facility. It allows you to benchmark with other facilities as well as benchmarking against a national average. It can be helpful, and we're going to talk about this today, helpful to incorporate those surveillance definitions into the process when your nurse calls a provider. They're also helpful for doing staff and provider training. We'll start with the McMaster criteria, as it is probably the most common one used in long-term care. It really has two components. It's based on the symptoms of your resident as well as the culture reports. Both of these have to be met in order for it to sort of meet the definition. There are different parameters when the catheter is present or not present. And again, the most commonly used in long-term care. So we'll go over these a little bit. The first one is McMaster's without the catheter. So in this, you have to have at least one of the following, along with meeting the culture criteria we're going to cover in a minute. So acute dysuria or pain, fever or leukocytosis, which is an increased white cell count, and greater than or equal to one of the following: acute costovertebral angle or suprapubic pain, gross hematuria, new or marked increase in incontinence, urgency, or frequency. If you have no fever or leukocytosis, then you have to meet greater than or equal to two of the following: suprapubic pain, gross hematuria, or the new or marked increase in incontinence, urgency, and frequency. When there is a catheter, the definition changes. You need to have at least one of the following, along with the culture criteria we're going to cover. So fever, rigors, new onset of hypotension with no other identified infection site that might be causing that fever. Acute changes in mental status or functional status, again with no alternate diagnosis, and leukocytosis. New onset of suprapubic or costovertebral pain or tenderness, or purulent discharge. Again, note that in both of these definitions, it's acute changes, new onset of pain, something that's different from the norm for that resident. When we talk about the culture criteria that has to be met, the definition is really based on the amount of growth of bacteria when it's grown out in the lab. That's called the colony forming unit, or a CFU. So without a catheter, you have to meet one of the following criteria: greater than or equal to 10 to the 5 of no more than 2 species in a voided urine sample, or greater than or equal to 10 to the 2 colony forming units of any organism collected by an in and out or an intermittent catheter. So how does your laboratory report these? Are you seeing this type of number? And if you're not, then you need to contact your laboratory so that you know how they are categorizing the growth on their plate. For example, 10 to the 2 or 100 colony forming units, 10 to the 5 or 10 to the 6. 10 to the 6 would be 100,000 colony forming units, and that's typically the highest number that a laboratory is going to report out. But if they are reporting to you moderate growth, heavy growth for a urine sample, then you need to talk to your laboratory and find out what their criteria is for those terms. Because in order to really see if it meets the McMaster's criteria, you need to have those values in a colony forming unit. Lobbs criteria is another criteria used in long-term care settings. It's based strictly on symptoms. So if there's no catheter present, you either have to have acute dysuria or a temperature above the baseline and one of the following new or worsening symptoms. So urgency, suprapubic pain, urinary incontinence, frequency, gross hematuria, or costovertebral angle tenderness. Again, note that it's either the dysuria or the temperature, and whichever one of those two you have, then it's the new or worsening symptoms listed below. If there's a catheter present, that definition changes, and you have to have at least one of the following. So rigors, new onset of delirium, a temperature greater than 100 or 1.5 degrees over that resident baseline, and new posterior angle tenderness. Again, note the use of the word new in the criteria. NHSN can also be used to determine presence of a urinary tract infection. It again works on both components of symptoms and culture reports. You have to have both in order to meet the definition. NHSN is categorized in 3 classifications, either as a symptomatic UTI or a SUTI. A symptomatic UTI with a catheter present, which is a CA-SUTI, or asymptomatic bacteria UTI or an ABUTI. So plenty of initials to go around. Now, at this time, it's not required to use NHSN to calculate or to report your UTIs, but it can be helpful due to the types of reports that you can pull out of NHSN once you put your data in. So we aren't going to go over the specifics of each of those 3 classifications, but please refer to the NHSN guidelines, and we'll have a link to those at the end in the resource section as well. So surveillance definitions, we've used them for a long time. Historically, I think most of us have used them retrospectively. So we look at data once it's already sort of done and said. We use it to determine a facility rate of infection. We then report those to our quality committee. But I really want you to think today about how you might be able to use those definitions to evaluate your resident at the time of the discovery of the signs and symptoms prior to your calling the provider. So again, typically you're going to have a concern for a resident due to signs and symptoms. Many facilities have a criteria checklist or a work list that they're completing, so that when you call the provider, you have all the available information that that provider might need. Are you requesting watchful waiting, such as pushing fluids and then alerting the provider for additional changes? Are you really asking that provider for a UA or urinalysis order? Are you looking for a culture order or an antibiotic order? The more information we can give that provider, the better decision they can make for your resident. So really, what are they looking for? What new symptoms are concerning you about that resident? How does that compare to the baseline for that resident? That provider you're calling may or may not be very familiar with that resident. There's an interesting quote in an article published by Drs. Mace, Drinka, and Cernich that says, clinicians must make treatment decisions in real time, often during a phone contact on the night of the disease. So if we look at it from their standpoint, they're getting a call on a resident they may or may not be familiar with and being asked to make a decision in the moment. So the more information that we can give them, the better it will be for them. So if you're using a checklist, formally, informally, to evaluate this resident change in condition, it should include at least the following. What are the current signs and symptoms for that resident? What are their current vitals? How does that relate to the background diagnosis for the resident, or what is their past history? Have they had any recent antibiotics? Do they have any allergies? Are they currently on an anticoagulant or other medications? We know that especially with anticoagulants, there can be a reaction between an anticoagulant and an antibiotic. So we want that provider to always be aware of whether they currently are on an anticoagulant. Also important to know what is the wishes of the resident, what is their code status, etc. But really, you are the expert on your resident to give that provider any pertinent information. You know your resident best. What is going on right now that has you concerned? Thereby, why are you calling them? And then again, just a reminder, as with everything, to make sure that this is documented well. So the Wisconsin Healthcare Associated Infections and Long-Term Care Coalition has been working a lot on developing messages that perhaps your staff could use when they are calling the provider. There are similar resources available for Minnesota and Michigan as well, and those resources will be at the end of the presentation as well. And these scripts will not only make your process more standardized, but they can really be helpful, especially if you have, say, a new nurse who doesn't have a lot of experience calling the provider or is hesitant to call certain providers with a change of condition. So think about, how is the provider likely to respond to each of the following statements? This resident is exhibiting localized urinary tract signs and symptoms with hypoxia and warning signs of fever and tachycardia. Versus the statement, this resident is exhibiting local signs and symptoms of localized urinary tract infection without warning signs. This gives the provider a very different picture of what's going on with your resident and what they might choose to do. What are you really asking for? Are you looking for the urinalysis, looking for a culture, an antibiotic order, or watchful waiting? Again, this is an example of a script that you might use. According to our understanding of best practices and our facility protocols, the information is sufficient to indicate an active urinary tract infection. We request permission to obtain a urinalysis, continue to encourage fluids within the resident's fluid restriction guidelines, and continue to observe. We feel at this point the resident does not need an immediate prescription for an antibiotic, but may need further evaluation and treatment. We will update the physician with the results. So there's one possible scripting that you might use. Again, here's another example. According to our understanding of best practice and our facility protocols, again, you're always sort of leading them to think about what is best practice, what is our facility protocols. So this is just kind of that gentle reminder that those protocols are in place in your facility. The information is sufficient to indicate an active urinary tract infection. We request an order to obtain a urinalysis and culture. Please advise regarding any further treatment. So again, another possible script. In order to really use this type of scripting to prompt your nurses, you also want to make sure that your medical director is very involved in those decisions as well. You should have had this process, worked out with them. They should be very involved in discussions about use of their criteria, how that information is communicated to your providers. Your medical director should be involved in the review of an antibiotic that does not meet criteria, may be an unnecessary antibiotic. They can really help to collaborate with providers to establish minimal criteria for ordering urine diagnostics, such as a urinalysis and culture. They also can promote decision support tools for reporting changes in the condition of your resident to the provider. So again, the role of that medical director is really key in this process. Also important is using these various resources to really educate the family and the resident. How many of us have heard this kind of a request? Mama always acts like this when she has a UTI. I want an antibiotic order. So the more education that you can do up front, at the time of admission, and then periodically thereafter, you will have much better luck reaching these family members and waiting to do it at the time that they feel that their loved one might be in crisis. Another important aspect is your specimen collection. So your urine specimen should not be collected properly. So you want to look at the policy for collection of the sample, both when a catheter is present and when it isn't. Your laboratory often has good guidelines for this as well, but also making sure you're looking at those laboratory guidelines for how a urine specimen should be processed once it is collected. In the ideal situation, within 1 or 2 hours of collection, if it can't be processed within that 30 minutes of collection, it should be refrigerated, should arrive at the lab within 24 hours unless a preservative is used within that collection system. And how many of you know if your collection system really uses a preservative? So again, this is the time for you to reach out to your laboratory and make sure that their guidelines are written into your protocols on how to collect a sample. So we'd like to open it up for some discussion. So after the information that has been presented, we'd like to know how many of you require your nurses to complete a resident evaluation sort of on a checklist or on a worksheet before calling the provider. Now that might be a paper form, it might be part of your electronic medical record. And if you are using that sort of checklist, has that helped with your calls to the provider? And if you're not using a checklist, really, what is your process? So your experience is really most helpful to your peers on this call today. So we would ask that you really share your process. Again, you can put it into the Q&A, as well as clicking on the raise your hand icon if you would like to say it aloud. And then Tracy is going to help us monitor that chat as we go.
Diane, would you give Christy the ability to unmute herself, please?
And do we have any questions in the Q&A or any responses to our discussion questions?
Yes, I do have a question that I'm beginning to type the answer. So new or marked increase in urgency incontinence and whatever the third one was, are all those considered just one criteria, or are they individual criteria that can help meet the greater than 2? So I'd started answering that there must also be a fever or increase in leukocytes. If not, then they have to meet 2 of the following: suprapubic pain, gross hematuria, new or marked increase in incontinence, or increase in frequency.
Thank you, Tracy. So we really encourage you to put your answers to these discussion questions into the Q&A or raise your hand. Are you using a paper or an electronic form of a checklist? Has this helped with your calls to the provider? And if you're not using that kind of checklist, what is your process for your nurses to really evaluate that resident before they call the provider? Perhaps this idea is a little bit new to some of you folks on the call. We have used this process for some of the facilities that we've been working with to reduce their UTIs, and they have found it very helpful. So it looks like Shane has raised your hand. Tracy, are you able to allow Shane to ask his question?
You need to make me a co-host. I'm unable to do anything right now.
Thought we did that initially, but let's Let's do it
I think you
again.
made me a panelist, but not a co-host.
All right, sorry about that. So now you are listed as a co-host.
All right.
We'll get all this
So
technology down.
Shane should have received an alert asking her to unmute herself.
Him, actually.
Oh, sorry, Shane.
Nope, that's all right. I was just commenting on the question, I guess, that was up there. I know one of the things that our facility has done is we've developed a urinary change in condition algorithm that kind of goes through the McGear's criteria for the line staff who are working with the resident with a change in condition. It's built right into our electronic health record. So as they're going through the urinary screen and documenting this change in condition, they have access to that right at their fingertips to let them know, change in condition. It's kind of yes, no, and it guides them through the process then as to what they should be, like what the kind of suggestion is in terms of how we update the physician and what we're asking for at this point in terms of like getting a sample, just watchful waiting, things like that, I guess. And that seems to work pretty well for us. We do a lot of individual education with the staff too.
Thank you so much for sharing that, Shane. And I'm curious also, was this sort of presented to your providers as well so that they knew that that was an expectation before the nurses called them?
That I'm not sure about. We do have a medical director now who I think is seeing, I would say, the majority of the residents for primary care while they're residing here. And she has been great in terms of antimicrobial stewardship and is familiar with the McGear's criteria and is really open to having discussions with us about these things and providing good clinical rationale if something doesn't meet McGear's criteria. After hours physicians, obviously that's a whole different story. But my role, I guess part of my role as the IAP here is I review all of the nurses' notes the following day. So that's something that if it's not caught at the time, the night before, typically we don't see antibiotics just getting started, I guess. Well, I don't know. I guess it's just, we do have a process. Like I can see that the next day though too, and I can intervene at that point or kind of help pull all the pieces together and try and figure out if something was done outside of what would be expected. Just tying that bigger picture together and figuring out why we're doing that or getting a change in treatment if it's warranted.
Excellent. And I want to reiterate one of the points you made, Shane, about documentation of that clinical review, whether they met criteria or not, especially if they didn't, why the decision was made to give that antibiotic. Again, just because they don't meet the criteria doesn't mean that the antibiotic may not be indicated, but the documentation of that discussion is really important. So thank you so much for sharing that. Would anybody else like to comment on your process about how it's done in your facility? Again, no requirement to use this checklist. It's just one tool that might be helpful. Perhaps you've trained your staff so well that it's not needed, but we'd really love to hear from those folks on the call. We'll give you a few minutes to kind of think about those questions. We'll go through our resource lists that I mentioned earlier, and then we'll kind of come back to this. So think about it if you would, and see if there's any information you can share to your peers on the call.
Yeah, it looks like Ginger says they use the McGear criteria. We follow care paths for UTIs.
Excellent.
And someone else, Clean, had put in the Q&A that they use the S-bar.
Okay. So again, this is just one example of a tool. These are other good examples that your peers have given, which is kind of making that process as consistent as you can, so that when that call comes into the provider, they know they'll always get the correct information. This is a listing of some of the resources we've mentioned today. Again, each of our states has some great resources that are listed here. The listing for the McMaster criteria itself, as well as Lobbs, and then the UTI protocols for NHSN. And as you remember, there was a few more steps involved with those and 3 different classifications. So if you are thinking about using those, these are good links for you to check out.
Diane, there's a few things in the chat. So,
I'm sorry, I'm having a hard time hearing you.
okay, can you hear me now?
I cannot.
Huh. So let me.
Nope,
Oh,
you're
now
better.
we can.
Yep, now it's good.
Okay, not sure what the problem was. Okay, so a couple things in chat. Ginger shares that they follow care paths for UTI. They use the care paths. And Carrie shares that they put a book together to interact that they use. And
Excellent.
couple good ideas.
Yeah, and Jim says we use a 3-day UTI protocol worksheet, which has helped to improve assessment and reduce questionable treatment. Asking, please address the mental status changes often noted, and they're somewhat conspicuous, absent from the McMaster's criteria. Conspicuous, I'm sorry, I can't read today.
Again, you know, none of these criteria are probably perfect, but looking at the resources listed here, trying to follow them as specifically as they are written. Your resident may not fit exactly into that definition, but it is just a guide for us to try and use.
I would like to add to that, that sometimes a change in mental state can be a symptom of sepsis. So even if maybe it doesn't warrant antibiotics for a UTI, there might be something else going on. So I would recommend just looking for any type of infection, not necessarily a UTI.
Thank you, Tracy.
And Carrie wanted me to just clarify that the book they put together is with the Interact. It's got Interact tools in it.
Okay.
The Interact assessment tool.
Yeah, I mean, if you can build this into your electronic medical record, it's always going to be easier for your staff than to be grabbing some kind of paper worksheet that they might not be able to put their fingers on. So really, you know, if you're lucky enough to have the option, utilize that into your electronic medical record. Well, thank you all for your comments. Any more information that you'd like to share with your peers? So I did put the link to the slides in the beginning of the chat. It will also be posted on the Superior Health website. And the session has been recorded, so the entire session will be posted there too. That typically takes a week or so.
There's one more comment in chat from Kelly.
Thank you.
And she says, not related to the discussion, however, wondering if a resident were to have more than 2 organisms cultured in a urine culture, looking at the McMaster criteria, it looks as though they would not meet that aspect of criteria because it is greater than 2. Is that correct? And do you know the reasoning behind that?
Sure, I can speak to that a little bit. So that is correct. That is how the definition is written. And the reason for that, if you think about it from the laboratory standpoint, so it would be very rare for a specimen to be collected properly and to grow out more than 2 organisms. So typically growth of more equal to or more than 2 organisms is a sign that that specimen was not collected properly and was potentially contaminated during collection, or it wasn't refrigerated, or it wasn't preserved according to the directions from your laboratory. So that is really a sign that you have to take that into consideration, that that may not be a true infection. Perhaps you need to recollect a clean sample in that case. But very good question. Thank you for asking it.
Shane has a question as well. Can you elaborate on the acute functional decline within the constitutional criteria? Is the 3-point scoring something that is done as part of the MDS, or can we assign a score right in the moment and compare it to what they are normally care planned for?
Sure. So I'll start that discussion and then I want to throw it back out to the participants. Again, any criteria such as McGear's is not going to cover or be very specific about everything. So looking at their definition, you know, what is it that you would normally use for your definition of change in mental status? Looking for that information, and if anybody that's on the call would like to share more information on that, it would be really helpful. You need to think about, you know, the McGear's criteria, Lobbs criteria, they're all sort of a starting point. And it's easy to say change in mental status, but what does that actually mean? But if you're concerned enough about that to be calling your provider, then I would suggest that you should be telling them, you know, here's what's different about this resident right now. Here's why I'm concerned. This is not their usual way of acting, of presenting, and this is what's causing my concern. Would any of our participants like to give any further information?
Diane, this
Yes.
is Kathy. Can you hear me?
Yes, thank you,
Okay.
Kathy.
I think also besides that change in cognitive status, you really need to have a good baseline set of vitals for this person. And I would put them on a monitoring, a close monitoring while you're assessing this. Change in cognitive status alone can happen for many reasons. The person may be dehydrated simply and experience a change in cognitive status. So that doesn't seem to be enough alone. And most physicians won't order an antibiotic, or maybe you can get a UA with just that piece. But to use the other criteria also, to have a good baseline of what is an elevated temperature for this person, to also look at how much they're eating, other things, how they're feeling, can they express themselves, those kinds of things. So I think you need to have a good clinical assessment of this person besides just the single symptom.
Thank you for sharing that, Kathy.
And Diane, Wayne Peterson shares that if you search and download the revised McGear criteria for infection surveillance checklist, it's a really good sample that they pulled from ASAP Table 1 and gives good definitions.
Thank you.
Can I elaborate on my question?
Absolutely.
So, and somebody just made reference to this, the ASAP or ASAP, but so what I'm looking at for McGear's criteria, there are very specific definitions that are provided for what constitutional criteria is. It tells you what the definition of a fever is. Leukocytosis isn't just an elevated white count, it's greater than 14,000. Like, it has that specific stuff in there. But so when I'm working with like my case managers, you know, they can report because they know the residents pretty well, and the floor staff do too, and they'll say, you know, they're having a change in mental status. Well, there is a specific definition provided for that. Or they'll say there is a change in their functional status, but the definition that's provided for that is a 3-point increase in baseline ADL score. And I'm a newer IP, and I'm just wondering, is like, I'm not aware of our facility like assigning a 0 to 4 ADL score for people. Is that something that's captured as part of the MDS process that we're looking at? Or is that just something that in the moment I can say, well, you know, normally they're completely independent in bed mobility, but today they're dependent. So that's obviously a significant change. I guess what's the standard that I'm being held to if a state surveyor or someone is in the bill? I mean, are they really nitpicking and looking at that very specific definition that is provided for acute function in there that says they're different today from what they were before, and this is what that looks like?
And I think you bring up a really good point. I mean, really, as Kathy said too, you're looking at the entire picture of what's happening with that resident, documenting those changes. And, you know, I feel free for the rest of the participants to kind of chime in here on what's been your experience when a surveyor looks at a specific resident, a specific antibiotic being given. You know, what kind of documentation have they been requesting from you all?
Shane, this is Kathy, and I think I understand your question, and it's a great question. I think that you don't have to go back to the MDS and compare that. I've never seen a surveyor in my 40 years of working in long-term care go back and look at that comparison to what an assessment was in the moment. So I don't think you have to go back and look at that. If they're functionally not able to do what they were able to do yesterday, yes, that's a change in condition. And so you will want to monitor that and then make the assessment based on other criteria, whether or not a call to the physician is indicated or not. And I would just have your nurse managers or your care team do that good documentation and make sure that there's good assessments going on. But you don't have to go back to that MDS and pull up criteria.
Thank you, Kathy. Some great questions. Anybody else from our participants want to share their process? What things they've been able to improve upon by using this sort of a scripting method or the change in condition checklist, how that's been helpful for your facility? Do we have any more questions or comments in chat?
There is one last question in the Q&A. Are you going to send out the slides from last week? I will get the link and send it out to you. Otherwise, hopefully you've found the YouTube recording in there. It also tells you how to find the slides. So
Thank you, Tracy.
And there's nothing new in chat, Diane.
All right, thank you. So again, the questions, if you have some you think of later, my email and phone number is on here as well. I encourage you to listen in for our next week's session, which will be on antibiotic stewardship. That will conclude our 3-part series. Thank you all for joining today.